I want to just take a moment to step back, and I know many of us have been hearing about variants, but just to give a quick primer. So when we're talking about variants, what this really means is viruses, as Dr. Colfax said, normally mutate randomly. This happens all the time. When the mutations sometimes cause them to be less fit or transmit less easily, we don't hear about them. Occasionally, randomly, there can be a mutation or a grouping of mutations that causes the virus to become more fit, to actually be able to transmit more, make people more sick, and that is what we are talking about when we talk about variants. These are random occurrences that then spread in our populations. So in San Francisco, we have not identified the variants of interest that have been nationally talked about. So these are the variants that started in the UK, which is known as B117, the variant that began in South Africa, which is B1351, and the variant that started in Brazil, which is called P1. And again, to be clear and to be very simple about it, this is different than the testing that we all know and think about now for many, many months, where we'll go and get a swab in our nose and get that diagnostic test. That is done in very many labs across the city and the region. The sequencing is actually the test that we need to do to find the variants. And what that is looking at the genetic material of the virus, of actually sequencing the virus genome to be able to see what the mutations are. That only occurs in a few specialized laboratories, and we're very fortunate in San Francisco that we have strong collaborations with our colleagues at UCSF and at Chan Zuckerberg Biohub, both of whom are experts in doing this type of work. But for context, as a country, we do not have the robust infrastructure to do this very, very systematically. So we are, by necessity, not able to sequence the 6,000 plus specimens that we are testing every day, and of those, the positive number, the 2 to 3% that are positive, not all of those can be sequenced because of the capacity and the specialty issues. So by definition, when we talk about variants, we don't have a complete picture across the world, across the country, in the Bay Area or in San Francisco. But we can get a glimpse of what we think is happening by how frequently we find different variants in the specimens that are tested. So from what we know, there has been the UK variant identified in California and in the Bay Area. And in fact, California has the second highest number of cases in the United States right now. So we have to assume that there could be that virus circulating in the Bay Area and in San Francisco, but we have not identified it. What Dr. Colfax said is so important. We know that the prevention methods that we've been talking about for a year are what will stop and slow the spread of these variants, even before we're able to access vaccine, which is, in fact, our ticket out, because the vaccine in studies have still been shown to be effective against these variants, and particularly against preventing against severe disease. So while vaccine is the ticket out, we have the ability in our hands right now to stop transmission of any virus, including variants, by masking, by distancing, by washing our hands. And I want to add one additional wrinkle to this, which I think is also really important and hopeful. The less virus that is transmitting and replicating, the less chance we have of having new variants emerge. So we talked about how it's a random mutation, but every time the virus replicates, there's another chance for a random mutation to end up resulting in a variant that would be of concern for a faster spread, making people sicker, or concerned with the vaccine. So we have the power in our hands to not only stop the variants that we know now, but also to prevent new ones from emerging. So I would really urge all of us to take the standard prevention methods that we have. In public health, as a department, we are working to understand the types and distribution of variants, not only in San Francisco, but regionally and in the state. But in the meantime, we really ask everyone's help in trying to reduce the spread as we know how to do now. What we know from the models and what we understand from science nationally is that the UK variant, because it does spread more quickly person to person, is likely to become the dominant strain in the United States by March. And so we don't have any reason to think that that'll be different in San Francisco. But again, we have the ability, as we have done time and again, to not necessarily let the models become our destiny if we are distancing, washing our hands, wearing face coverings all the time. And particularly as we are reopening and coming into contact with each other more, it becomes so important to do those things. There was a second part of the question about the West Coast variants. So this is a different strain of virus, which has been identified in California and in other areas on the West Coast. And this is called Cal.20C. And it has been identified in some outbreaks, not again in San Francisco, but it has been identified in individuals from San Francisco and in the Bay Area. But our colleagues at CDPH and at CDC are still evaluating all the data to understand if it is in fact more easy to transmit that variant and what all the implications are. So we don't have a clear understanding yet of the implications, but we do know it's transmitted the same way. We have no reason to think that the vaccine would not be effective against this variant or any others.